Welcome to We're on ECMO, an educational series for the extracorporeal community. And today we've got a special guest, Jana Alley. She's the clinical director of Sentinel Medical Technologies. She has a dual board certified in emergency nursing and trauma nursing. She's been an RN for the past 10 years, and she is a passionate advocate for restructuring nursing pay and ending nursing violence. And she's here today to talk to us about IAP, or intra-abdominal pressure. Jana, thanks for being here.
Awesome. Thank you, Neil, for having me on, and we appreciate it.
Yeah, absolutely. And IAP is a topic that perhaps hasn't gotten the attention that it deserves. And so, first off, I just want to start today asking if you could give us an overview of what IAP is and why clinicians should be interested in IAP in general.
Absolutely. So, IAP intra-abdominal pressure is a pressure that's going to be happening inside your abdominal cavity. You can kind of correlate it between the pressure that happens venously through your blood, the blood pressure, pressure that happens when you're in the muscle cavities, when you're getting compartment syndrome. It is a pressure that forms on a gradient that's exerted within the abdominal cavity. We don't monitor over the past years. We know it's there. We know it's a detriment. We just have not been monitoring it the way that we should have. Oddly enough, most other countries monitor this religiously, like they do their other parameters and measurements for vital signs. It is a vital sign that they monitor continuously. We're just over on this side in America, we're a little bit behind the curve. And why we need to be monitoring it, it's no different from any other pressure. Any pressure exerted in a space inside the body that is contained is going to have a detrimental effect somewhere because it's squeezing something, whether it be pressure that goes to your brain and creates a stroke, whether it's in your muscles and creates compartment syndrome. The same is going to be happening inside your abdominal cavity. And we need to monitor that pressure because the pressure that's happening inside is creating a squeeze essentially on your organs and creating less of a perfusion in your in perfusion pressure for your organs, killing organs. So no different than how we should be monitoring blood pressure. The same we should be monitoring intra-abdominal pressure in the patients that are at risk.
Absolutely. It's like great information. It's just kind of crazy that, it seems to be overlooked in a lot of places, especially here. And it definitely seems like something that stands to benefit, patient care, patient outcomes, and the clinicians as they care for those patients. And of course, at ECMO Advantage, we're, advocating for those in the ECMO space. And so I'm wondering, how can this monitoring of AIP be valuable specifically for those caring for patients on ECMO?
Sure. So, what we need to understand first is how it's traditionally monitored now. Over past years, few decades, you're going to monitor generally. There's multiple ways you can monitor through the stomach, through an endotube, but most common it's going to be done through the bladder, a bladder pressure that's obtained through a standard Foley catheter. The nurse or whoever is going to be taking the pressure lays the patient down, hooks up a line or inserts, saline into the bladder, retrograde filling the bladder, has to be leveled at the iliac crest. Most of the time, they need to be paralyzed so that we can take into account that end expiratory pressure because that pressure exerts pressure on the bladder, gives us a false reading. Multiple steps to do this, and then you get a pressure up on the monitor, and that tells you based on a grade if your patient has intra-abdominal pressure. Now, it's all graded according to the WSACS, which is the World Abdominal Compartment Society. They say that 10 to 15 is grade one, and 15 to 25, I believe, is grade two. I have to remember those numbers. I get them mixed up quite a bit. But for the all the nursing and anybody clinical, you start to go ugh after 12, and anything above 20 is an abdominal compartment syndrome.
Mhm.
So in the space between 12 and 20, it's often overlooked. You'll get a few pressures and it's intra-abdominal hypertension. A lot of times things are not done with intra-abdominal hypertension. Once it gets over 20 in abdominal compartment syndrome, that's when we start to worry or that current practice is to take action then. Oftentimes, though, that 12 to the 20, not much action is taken. And even though it's not abdominal compartment syndrome, it's the same as a blood pressure when you're going to have a stroke. Do we wait till you're at 220 systolic to treat a stroke? No, that's
Mhm.
the same as we're looking at intra-abdominal hypertension. We say, oh, let's wait till it's 20, and we need to do what's called a decompressive laparotomy, which is when you open the abdomen to release the pressure.
Mhm.
Um, when you think of it like that and you say, wait a second, we're not going to implement some measures between 12 and 20 or 25, we're just going to kind of let it sit before we do something. You go, that's the same as having somebody with a high blood pressure and saying, we'll wait till it's 220 to give some labetalol. We'll kind of wait till they stroke out till we do something.
Yeah.
So you think about that and you say, wait a second, that's really not accurate. But the way that we're measuring is very tedious. It
Mhm.
is oftentimes not accurate. There's nuances then that's involved in taking the pressure that, does the nurse know how to do it? Are they competent to do it? Did the patient move? Did they level right? Did we give enough paralytic? Baseline IAP for an obese patient is going to be higher than a normal patient.
Mhm.
Multiple factors come into this, and then they're kind of left with this, oh, we have this number. Let's hope it clinically correlates and let's act on it.
Mhm.
So as far as when in the ECMO setting, and I myself am not an ECMO provider, but or I've never really experienced a lot of ECMO, but it has become of a huge interest. And we have done some research lately, and there was actually an article posted in the Society of Critical Care Medicine Journal in January of 2019, and it was titled ECMO's Association with Intra-Abdominal Hypertension and Abdominal Compartment Syndrome. And they did this in a pediatric population.
Mhm.
And they determined that the intra-abdominal hypertension and abdominal compartment syndrome were associated with mortality in 60% of children, and that IAH was an independent predictor of mortality.
Mhm.
And the reason that the reason for the IAH and ACS was the fluid resuscitation. We know in ECMO we're given lots and lots of fluids. And then that coupled with the bowel ischemia reperfusion caused an increase in capillary permeability and the extravasation of fluid into the mesentery, which in turn increased your IAP.
Mhm.
In this study, the WSACS says that IAP in a child is greater than 10, IAH is greater than 10. For their study purposes, they only just considered IAH greater than 20 for a prolonged 8 hours. And they decided it was kind of too difficult to determine, was it ACS, IAH causing the issues, or was it their original reason for being placed on ECMO?
Mhm.
But in the event, they determined what they wanted to do on this study was determine if there was an association between IAH on ECMO and AKI. At the end of the study, they put in 31 patients, and the patients were 37 weeks to 18 years, and the IEP was monitored every 4 hours prior to being placed on ECMO, 12 hours prior to being placed on ECMO, and for 7 days on ECMO. Out of those 31 patients, 26 or 84% developed IAH, and 2 out of the 31 developed abdominal compartment syndrome. And
Mhm.
of those 26 patients, there were 43% that developed acute kidney injury. The conclusions of the study were that they associated ECMO, being on ECMO, with the incidence of IAH, intra-abdominal hypertension, and nearly half of those patients had AKI. They determined that they were able to take intra-abdominal hypertension, predict mortality, and predict onset of AKI or the
Mhm.
incidence. That's pretty big. And they go
Mhm.
on to say in the study that they didn't have it was a small study. It was retrospective. They did what they could with what they had, but all the studies that are out say we need more information. We need more information.
Mhm.
Why do we need more information? Why are we not getting it? Because of the difficulties in obtaining a bladder pressure, we aren't able to get accurate and consistent data.
Mhm.
Which, when you think about it today, everything in critical care is generally based on a continuous model. We can get blood pressures every minute. We can get blood sugars every minute. We can get everything every minute, but to get a bladder pressure is an evolution. It's
Right.
a big deal, and most often times it's not accurate. So we haven't been able to present data to make decisions to say, hey guys, intra-abdominal pressure, ACS on ECMO, it's really having an effect on our patients.
Mhm.
When we moved to a study for adults, and this was done at the University of Maryland, patients on VV ECMO, they determined that they were at risk because the flow through the return cannula was compromised and resulted in inadequate end organ perfusion. They took 9 patients and they basically did a decom lap or decompressive laparotomy on all 9 patients once they reached a certain number based with clinical correlators.
Mhm.
The median pressure before they opened them was 27, and they decided that all the patients had inadequate venous drainage with associated hypoxemia, and the median time from cannulation to diagnosed abdominal hypertension. And they did a expedient laparotomy, and it was all done within 72 hours. The overall survival rate was 56%. So that's if I'm on ECMO, I don't like that number that
Mhm.
they're saying that only 56% survived. They did pressures the same. It was done over 72 hours, and they did every 4 hours, which equals 18 measurements. If we think about that, and in their study, they said that their limitations were, quote, subject to subtle variations in technique and patient position and did not always clinically correlate. And that was a limitation. So let's take that and say that 50% were correct. You have 9 accurate measurements that you have based opening a patient to produce a better flow to save their life. And those were 9 measurements done in 72 hours. But how many other measurements were taken and other things, blood pressure, heart rate, SVR, we have an art line. We have multiple other things being monitored much more frequently, but we're going to open a patient based on an IAP that was accurately measured maybe 9 times correctly.
Mhm.
Right now, that's going to be the setback in there. The company that I represent is Sentinel Medical Technologies, and we have Trauma Guard. And Trauma Guard is a continuous intra-abdominal pressure monitoring device. It monitors a pressure 50 times a second. You do not have to level at the hip. You do not need to paralyze the patient. It's taking all of that data and creating a mean pressure. So you're getting a continuous reading on the monitor. We need continuous technology to measure IAP. If we go back and we say, what if we had measures in place, we had this data so that the patient, before they got to 20, it's not that we don't have anything that we can do before 10 to 20. We can do bowel decompression. We can do abdominal decompression through an NG tube. We can give medications, so bowel evacuation. We can do some multiple things, give some positioning, nursing interventions, and physician ordered interventions that can help this patient possibly never even reach 20. However, if it's inevitable that this patient is going to have intra-abdominal hypertension and abdominal compartment syndrome, instead of waiting till they get to a mean of 27 and we've done everything, we can open them earlier and we can prevent the end organ damage failure and possibly see a 20% in survival rate. If I'm an ECMO patient, if I'm an ECMO provider, if I'm the one that's taking care of this patient, I like my odds of this patient surviving 76% over 56%. But
Mhm.
in order to bridge that gap between the 56 and the 76, we have to have accurate data, we have to have continuous data, and we have to be able to make decisions based on accurate trends from technology that is available to us 24/7 and not just on an as needed basis, like the
Mhm.
standard that we're doing now. I think one of the most important things too that we have overlooked is the way that we're getting these measurements are through a Foley catheter. And just as important for I don't care what part of the hospital you work in is CAUTI. You are
Mhm.
hand manipulating that catheter 18 times in 72 hours with unsterile gloves. You are putting unsterile saline into there, and we are manipulating a catheter. We are increasing our chance for CAUTI 18 times more than we could have if you were going to use a continuous measurement device, which you
Mhm.
no longer have to touch. So we have to consider those things as well. But in the long run, as we see healthcare moving, especially ECMO is so advanced. I mean, in my practice in the trauma world and the ED world, the ECMO nurses, when we know that, hey, ICU, they're going to ECMO, that's incredible skill and talent and knowledge go into that. the best of everything is given to try to keep this patient alive, we need to consider not having every once in a while measurements. We need a continuous measurement so that we can make a better clinical decisions based on more data.
Mhm.
I think that that's what's going to be interesting to ECMO providers and perfusionists and nurses, saying we're not basing cutting a patient open in a very high mortality procedure off some maybe okay measurements. We have data that is given to us 50 times a second. We're able to take that data and make decisions early,
Mhm.
accurately, and correctly in order to help give that patient a better chance of having a better outcome, a better and higher percentage of survivability.
Awesome. Well, thank you, Jana, for that thorough overview. That's a lot of great information. I know we are huge proponents of data-driven practice. We know that a lot of times, if you've got the right data and you're able to implement that and how you treat the patient, that of course there's better patient care and outcomes to be had. And so we appreciate you sharing that with us today. If you're watching today and you have a question that you would like to have answered here on We're on ECMO, make sure that you give me an email, Neil, Neil at ECMOadvantage.com. See you next time.